I'm going to be talking today about sort of how to combine primary care and mental health care services, which was actually one of the questions that came up earlier. And I think this is a thorny issue everywhere because we tend to separate people into, here up or here down, and never think about how can we put the whole person together and how can we treat the whole person and what do they need. So when I was, asked to do this, I started worrying, of course, because it's going to be a large group. And one of my worries was, well, I don't know anything about Karachi, and how am I going to say things that will be applicable to Karachi? And I know that there are many things that I'm going to talk about that may not be the perfect solution for here, but I'll tell you some things that worked in the States. And, so what I'm not familiar with would be like driving in Karachi, okay? So there, which I think it could take 20 years to get used to that whole concept. But at the same time, there are things that are very similar, like the holes in the street. In Louisville, currently there's only one road that I can take to get to my daughter's house because every single other road to her house is closed for construction. So I suspect that we'll come away from here with some differences and some similarities, and I'm hoping that we can have some discussion along the way and all learn some things. So I wanted to start off with just a little bit of background, okay? And we know that people with mental illness, with serious mental illness, die years earlier, decades earlier than the general population. And so when people started looking at this problem, they were confused as to what could the possible cause be. And initially they thought, well, maybe it's something to do with the mental illness. Maybe people commit suicide more often, and they do. Maybe that's the reason that the life expectancy is so much lower. But that's not really the whole picture. We know that close to 70% of the people with serious mental illness have a comorbid physical illness. And we also know that people are less likely to be treated for medical problems that have been identified. And so part of what I want to talk about today is the reasons that I think that people are less likely to get treatment and what we might be able to do about that to help to bring their life expectancy up to what we would hope it would be. So when we look at the increased mortality, we see that a lot of the reason that people are dying 25 years earlier than they should is because of cardiac reasons. So they're having, cardiac events, and that's shortening their lives. And when we think about serious mental illnesses, some of the things that contribute to that excess cardiac disease are things like obesity. It's people who, who have schizophrenia tend to be heavier. Metabolic syndrome, weight for weight, people who take psychiatric medications like atypical antipsychotics tend to have metabolic syndrome even compared to somebody of the exact same weight who's not taking those medications. Diabetes, which is sort of a sequelae of metabolic syndrome. Smoking. I don't know. I actually looked some at, it looks like there's a fair number of people with mental illness who smoke in Pakistan. I know in the States that the average is down to about 25% for, the population, except in Kentucky where I come from, which is much higher, unfortunately. We do a lot of tobacco research for that reason. But in people with schizophrenia, you get up closer to 90%. Okay, so many more people smoke, and many more people with schizophrenia tend to smoke heavily. So they're not just, taking a puff or two and putting the cigarette out. They're really dragging on it to get all of the nicotine that they possibly can. And all of these things contribute to people developing cardiac disease. Now, other comorbidities that we see, chronic obstructive pulmonary disease. Okay, so, in people who are heavy smokers for a number of years, you would expect to see people developing lung problems, and in fact you do. We see hepatitis and HIV disease, and that's related to people who are either using substances, drinking heavily, or maybe living in very close quarters. Like we have a lot of shelters. I think there's less family care in the US than there is here. So we have a lot of people who are actually living in sort of a big open room where, in this room you might have like 40 people living, okay? And they sort of come in and leave and come in and leave. And so you see some of the hepatitis and sort of happening from food and handling and contamination. And you also see tuberculosis, and some of those living condition reasons are the same for tuberculosis. If you have a group, unfortunately, with HIV disease who's living in close quarters and gets tuberculosis, often it's not, it's more difficult to treat, so it tends to sort of stick around in that community. Now, other things we know. So when people with serious mental illness have a medical illness, they're more likely to have adverse medical outcomes. Okay, so there are a couple of reasons for that, but it seems like it actually goes both ways. When you have people who have serious mental illness, if they have a medical comorbidity, their mental illness tends to be more problematic for them as well. So the costs of treating both illnesses increase, and in fact they actually are sometimes 3 times as high as it would be to treat any illness. And this really applies not just with serious mental illness, but with things like diabetes, asthma, and depression and anxiety. That, when you have people struggling with 2 problems, that it tends to be more difficult to treat either one, and the outcomes tend to be less good. Now, so obviously we have to find a way. We have to find something that works. And there's been a lot of sort of investigation of this problem in the U.S. because we really feel like we're not giving people quality treatment. And so we're trying to figure out a way that we can actually look at both physical and mental health problems and treat them both at the same time, and ideally in the same setting. Now, in the U.S., a lot of the that's an interesting noise. Okay, so when the jackhammers come through the ceiling, we'll all leave through that back door. Okay, so with sort of less serious mental illnesses, things like depression and anxiety, with the model that they're using, and the model that seems to work really well, is to treat people for psychiatric problems in their primary care provider's office. Okay, so you go to the doctor for a stomach ache or a headache, and they talk to you and they do whatever assessment they think is reasonable. And then they walk you down the hall and they do what's called a warm handoff. And they say, you know, this is somebody that I work with. She's a good person. She's going to sit down with you and try and figure out how we can make this less of a problem for you. And people, when they get introduced right away to the person who's going to be working with them, when they get a chance to sit down, it tends to work really well. People follow up, they find it helpful, they get better, and for the best, you know, in the U.S., the bottom line is everything, and so in fact, costs do decrease. So this kind of integrated healthcare is very effective in improving outcomes and decreasing overall costs. It works less well for psychiatry. So the reason that it works less well for psychiatry is that people with serious mental illnesses tend to go see their mental health provider before they go see their physical health provider. And in fact, where I've practiced, a lot of the people who have schizophrenia don't have a medical provider. So my friend used to say, you know, they have a primary care provider and it's you. So you have to step up and you have to make sure that these problems get addressed. So one of the things that they've been looking at recently is sort of co-location, but in the opposite direction. And there are actually a number of really interesting programs where they bring primary care services into a mental health treatment program. And so the person would get connected with their primary care doctor by meeting them through their psychiatric provider. The advantage to that is that the psychiatric provider in this instance is the person who has the relationship. They're the person who can say, I want you to meet this person. They're a really good person. I know they can help you. And, you know, I think that that's sort of necessary. People in the U.S., I don't know how it is here, but people in the U.S. are treated very badly when they have mental illness. And they're treated with a great deal of suspicion when they go to the doctors and they say, I have a headache, I have, you know, stomach ache, I have chest pain. People tend to say, well, you know, of course, you have schizophrenia. You know, go take your medicine, you'll be fine. And that's part of the reason why people die earlier, is because even when we, you know, could find problems, we tend not to look for them. And when we do find them, we tend not to treat them. And when we treat them, we tend not to use standard of care. And all of those factors, I think, are sort of born out of stigma, but they really do a disservice to the people that we work with. So here we have the reverse co-location, and I actually did a residency at a primary care clinic in Chicago when I was getting my doctorate. And the thing that I was doing was working in the primary care clinic, in the mental health center, and trying to do some health promotion of people around smoking cessation, around nutrition and exercise, and you know, trying to figure out some ways that we could increase people's wellness using both specialties, you know, sort of in the same direction. And it was very exciting. So I'll tell you a little bit more about that in a minute. Okay, specific comorbid problems. People with mental illness, like I said, are significantly more likely to have metabolic syndrome than subjects matched for weight. Okay, so there was a very large population study in the U.S. and they looked at all of these factors, and it came out that people with mental illness, pound for pound, were more likely to have a problem. And they really felt like that was due to the second generation antipsychotics, and that they have increased some of the metabolic, they're wonderful, okay? I think that they really have many fewer side effects than some of the older antipsychotics. But people do gain weight, they do tend to have more trouble keeping their blood sugar normal, and their cholesterol tends to go up. And sometimes you actually see the cholesterol going up first, even before a significant amount of weight gain or a significant disruption in their blood glucose. So with metabolic syndrome, does everybody here know what that is? Should I go ahead and explain it? I'm going to go ahead and do it anyway. Okay, so basically what you're looking at is people who start to, because of a number of reasons, have trouble with their weight, and their BMI is going to go up and possibly be above 30, okay, which is sort of where you start to see problems developing. They have what's called central obesity. So generally, if you put on weight and it's in, sort of in your hips, it's a healthier way to do it than if you're putting it in around your abdomen. So when you actually measure circumference of somebody's waist and somebody's hips, you'll see that the waist-hip ratio gets changed, so that the waist tends to be larger than the hips. So your ratio goes down. Thank you. Okay. You see disruptions in fasting insulin and 2-hour postprandial blood glucoses. So those things will start to show that this person has impaired glucose tolerance, so that they aren't able to use glucose effectively, and they keep sort of producing more and more of it. And their triglycerides, which is a form of sort of fat in your blood, will increase. Now, you also see as part of metabolic syndrome that the blood pressure is going to go up. And, if somebody's above like 135/80 at this point, they're considered to be hypertensive or pre-hypertensive. So every year, the numbers that we want people to be at are lower and lower. Okay, so that's a fairly complicated slide, but basically insulin plays a role in this. As people start to have impaired ability to use insulin, their body starts increasingly producing more and more insulin, sort of trying to get that sugar into the cells so that the body can use it. And what we know about insulin is that as your insulin level increases, so does your body weight. So we're actually sort of seeing the insulin resistance driving some of the weight gain that you see in people. And the weight gain drives the insulin resistance. So it's sort of like a vicious cycle. Indicators of insulin resistance would be, diabetes and impaired glucose, elevated insulin levels if you have the ability to measure those, and impaired fasting glucose of more than 100. So if you have like 100 to 109, you would call it impaired, and over 109, you start to worry more about development of diabetes. So that metabolic syndrome rates in Pakistan, I figured this would be more useful for you than what they are in Chicago. they're still pretty significant. And I was surprised when I started reading the National Diabetes Survey that was done in, I believe, 2009, reports that the incidence of metabolic syndrome in Pakistan is really increasing. And they predict, a recent study predicts that by 2040, that Pakistan may be the 8th in world incidence of diabetes. So it's really, really sort of increasing, and it sounds like it's going to become more and more of a problem. So this is probably something that it would be wise for everybody here to think about. Now, clearly, all of this is not happening because of serious mental illness. But people with serious mental illness are going to bear a disproportionate burden of this. Recent study of people with psychiatric diagnoses in this region showed that nearly 60% of people taking a second-generation antipsychotic, and so this would be like quetiapine, olanzapine, clozapine, aripiprazole, ziprasidone. Do you use a lot of that? Do you use risperidone?
Yeah.
Okay. So all the names are different, so I feel like I'm a little bit behind the curve in what's actually used here. But it showed that people taking a second-generation antipsychotic have a 60% rate of metabolic syndrome. So clearly this is something that you need to think of, you need to plan for, you need to respond to early so that people don't go on to develop cardiac. So why do people with serious mental illness have increased rates of metabolic syndrome? Some of the reasons are modifiable and some are non-modifiable. The non-modifiable are family history. You can have a family history of high cholesterol, high blood pressure, high triglycerides, diabetes, and there's really nothing you can do. That's your family, that's what you were born into, it is what it is. You can't change that. But there are many things that we can change. The second generations, that's a modifiable risk. And, they all have some risk, but clearly things like aripiprazole, ziprasidone, risperidone have less of a risk than things like olanzapine or clozapine. So you have to weigh sort of what are the risk-benefit ratios for these people that you're talking about meds with. Sedentary lifestyle. People with serious mental illness tend to sort of slow down, initially, and then once you're sort of on the couch, it's sort of hard to get back up and get moving. So they tend to have a sedentary lifestyle. I've talked to a lot of people who would say, I used to go to the gym, I used to go to the gym every day, I don't like to go to the gym anymore, it's too loud, there's too many people. I wonder if I can get this back in. The speakers? No, now it's working. Okay, now I know the fix. Okay, so they'll say, I used to do this, but now when I go to the gym, I'm worried that people are looking at me. I'm worried that people know I have a psychiatric illness. So there are some reasons, I think, that to do with stigma that cause people not to be out and about in the same way that they used to be. Dietary, obesity. Some of these medications increase weight gain, and people who have serious mental illness tend to sometimes eat more than is probably indicated for them. Dietary choices. Now this is one that I'm not sure how it applies in Pakistan. But we know that in the U.S. that people tend to really gravitate towards fast food. If they have mental illness, they do not cook. Only 30% of people in one study prepared any food for themselves at all. So where family is more involved here, you may see less of that as an issue. And then smoking. Everybody smokes, and that increases their likelihood to have this. So many of of these people, many of these factors are modifiable, and yet we often pass up the opportunities that we have to work with people on ways to modify them. And I think that part of this is that we as providers tend to say, well, they have this huge problem. They have schizophrenia. So it would be too much for them to try and diet, to try and exercise, to try and, figure out how they were going to eat healthy. And so we don't even talk with them about this issue. And in fact, it's hard for any human being to modify their behavior. And in my experience, it's not that much harder for people with serious mental illness once you figure out a plan that's going to work for them. I think the smoking is difficult, but we've had people who have started walking like a block at a time and gotten up to, walking several miles. We've had people who have started drinking 14 liters a week of Pepsi and gone down to 7 liters a week and then switched over to water. So, I think that part of the process is that you have to talk with people about what some of the risk factors are in their health. And you have to assume that they're interested in being healthy in the same way that you would be. Still hard to change behavior, but if they don't know it's a problem and if they don't know that you think it's important, it's probably not going to be a priority for them. So one of the first things that you want to do is to set up a mechanism so that you can detect this problem. And so often we don't really weigh people in psychiatry. We don't necessarily check their blood pressures, although that's quite good at Recovery House. They're very careful with this and actually do a very good job of sort of trying to discover all of these things as they're emerging. And they are easier to reverse if you catch them early. So providers have been notoriously slow to monitor. We know that if you find somebody whose weight has increased, if you do blood glucoses on people, if you do blood lipids on people, that you will discover variations. And then that gives you information that you can use to decide with the person, what do we want to do about this? How do we want to address this problem so that you stay healthy? Now, things that you can do fairly easily without a lab are looking at waist circumference. This actually may be a better indicator than BMI, so better than just height and weight. And it certainly lets you know whether the person has that central obesity. High risk numbers for waist circumference would be a male whose waist circumference is above 101, and females who have greater than 89. And you want to measure just above the hip bones with a tape measure that's snug but not tight. So you're right around the umbilicus. In Chicago, we used to do this over clothes, and we figured everybody was like a little less, but it just was much less traumatic than trying to get people to lift up their shirts or, it was just not appropriate. Then you measure hip circumference at the widest part of the hips. And, you look at the waist to hip ratio, and what you're going to see is that high risk in males is going to be above 0.9, where they're, almost flat, and for females it's going to be above 0.85. You can then determine BMI, and there are a number of BMI calculators online. The CDC has one that does it in pounds or kilograms. You can also figure it out by hand. It's kilograms over meters squared. But I don't know if I can select this. We'll just, okay. But if you Google, you know, like BMI calculators, you will be inundated with them. Then the next thing you want to look at are your fasting lipids. And you know, you have HDL, which is your good cholesterol, and that should be greater than 40 in men and greater than 50 in women. And the LDL, or bad cholesterol, ideally is going to be under 100. And triglycerides, you want them to be under 150. Now, like I said, those are often the first things that start to go up. So you want to, you know, catch them right when they start to go up, before the person develops diabetes, before things are more of a problem. Now, with blood pressure, you see, ideally the blood pressure needs to be under 130 over 80. And then, once you find these things, there are a number of lifestyle measures that people can take to try and address them, okay? Now, there are additional monitoring things that you need to think about in a population of people with serious mental illness. The first one is prolactin level, and you know, this is something that, a hormone that can go up in people taking certain medications that is very easily treated if you just switch their medicines over from risperidone to something that is not going to cause that. You look for movement disorders. The second generation antipsychotics cause many fewer movement disorders, but they do cause them. And what you'll see is Parkinsonism, you'll see akathisia, you'll see tardive dyskinesia. And you need to do some sort of screening for people, just even walking, you know, walking with them into the office. You need to be thinking about how are they walking, what is their facial expression, you know, can they sit still, or are they, you know, shaky all the time. Renal and liver panels, depending on the medications that people are on. You may want to look at, you know, how it's affecting their liver, how it's affecting their kidneys. Dental health. People with serious mental illness tend to avoid primary care providers, but even more than that, they avoid dentists. So you want to try and make sure that people get connected with dental care providers, at least to have their teeth cleaned, and that they, you know, are able to do that in a way that's not too traumatic for them. We're actually in Louisville now with a clinic that I'm working with, providing primary care providers in the dental office, so that if people come in for the dentist, that they can get a checkup and screening right then. And then you want to look at EKGs or cardiograms, so that you can see if people have some sort of changes in their heart rhythms. So that's the medical part. So the question is, where does psych rehab fit into all of this? Okay? And actually, it's a pretty good fit. For people with serious mental illness, you know, clearly it's easier for them to see somebody at their program than it is to go someplace else and find a new person who may say to them, oh, what do you expect? You have schizophrenia, go home. If people are already connected with the service provider, it makes sense to bring the other service provider into that location. And programs like Recovery House have a real advantage when it comes to integrating care. If they can bring the providers together in the same place, which Recovery House has done a very good job of doing, then they are able to use the staff in the program to address some of the lifestyle changes and some of the management of problems that are discovered. and help people to, sort of decide on treatment plans, to carry through with treatment plans, to implement things that might be difficult without some support. So I really see programs as being the place where people's modifiable risk factors are going to be most easily addressed. They have the experience of problem solving. So the strategy is first to examine, to screen for common comorbidities. All clinicians need to be aware of, indications that disease may be developing. And so this is something that, extends down through, through the nursing staff into the psych rehab staff, where you want people to notice, did this person get up during group and go to the bathroom 7 times? Oh, blood sugar, maybe we should tell somebody, maybe we should report this. So you want to have, you want to communicate with people some of the issues that may signal that a problem is developing. And often it is just that people are really thirsty or that they're really urinating quite frequently with diabetes. You want to do routine screening as part of appointments. For example, if you don't have, dedicated nursing staff, you want to do weight and vitals, you want to schedule labs, you want to develop some sort of system for keeping track of that. And, programs then can talk with people about what changes they need to make, and they can problem solve the things that don't seem to be going that well. So if somebody is supposed to be walking and they're not walking, you can say, well, what's the problem? I was working with one guy in Chicago who said, I go to the day program, I'm supposed to walk in the evening, I come home, I sit on the couch, I turn on the television, and then I don't want to get up anymore. So, for him, one of the solutions was that, well, you come home, you get off the bus, you live in this huge apartment building, can you walk around the block? So he started walking around the block, and then, once that was in his pattern, could he walk around the block twice? And so, sort of like figuring out what's the best time of day and what's the best plan for getting this to happen. And there's a thing in psychology that's called the PMHNP principle, where you want to connect a behavior that you want to strengthen with a behavior that's already pretty strong. And so for him, the sitting down on the couch and turning on the TV was his moment, okay? And so having the walking happening before he sits down and turns on the TV made it much more likely that he would follow through with it. And in fact, that solution did work for him. Now, things that can be negotiated as part of a treatment plan. When you're working with somebody on a rehab treatment plan, you're looking at how are you going to reclaim your life. A lot of times people are saying, well, I don't have any energy, I want a girlfriend, there's like lots of different, sort of things that people bring up that can be tied to lifestyle kinds of things. And exercise, I think that you can educate people about the importance of it, but you can also look at ways to decrease barriers. When I was talking about gyms and how, just noisy and unpleasant it was to go into this brightly lit place with all these people on treadmills at the same time. One of the things that has worked for some people is to, find out when it's less used. What is the quietest time at your gym? And, so when are you going to be able to go and find a treadmill without having to maybe be, in the middle of 15 people? I think you can also work on motivations. And one of the things that Recovery House does very well is to, do motivational interviewing with people And that's a way of sort of like helping people to discover their own reasons for wanting to change. And if you can connect it to their goal, one, like if a goal is to have fun, and one of your things that you used to like to do was to go dancing, but you don't have energy anymore, well, how could you, sort of start to build up some of that energy? Nutrition, I think, is something that is also quite a challenge, okay? I talked about people not cooking, but people, at least in Chicago where I did most of this work, don't really always have a lot of knowledge about food and healthy food. So there's a lot of educational need, but there's also, there's a number of people who present barriers that frankly surprised me, like people who, when you say, well, do you like celery, do you like cucumbers, they say, well, which one is the celery? Which one is that? When they say, well, I've never had a carrot, but I'd like to try one, and you say, well, where would you go buy a carrot? They say, I have no idea. So, you really have to sort of ask questions and make detailed plans, because sometimes people have the intention, but they aren't quite sure how to make things happen. In that carrot example, the nicest thing that happened was we were in a group and people were setting up their weekly goals for their lifestyle changes. And the woman next to the guy who wanted to try a carrot but didn't know where to buy it said, well, you know what? You can go shopping with the program tomorrow and you can buy a carrot across the street, but if you can't, let me know and I'll go with you. So, a lot of times peers can sort of support each other in exercise, nutrition, all sorts of programs, all sorts of behavioral changes. I think you want to normalize the difficulty of change. I mean, my provider has been telling me to lose weight for the better part of 10 years, and he's still telling me that. So it's like, it's my intention, but I obviously have not made it enough of a priority. So I think that it's appropriate to talk with people about this isn't an easy thing. And sometimes what I've seen with people, there's a group that I worked with in Louisville who were women who were recovering from drug addiction. And they were really interested in, doing more exercise, getting back in shape, getting their teeth sort of back into shape, learning about nutrition because they had children and they didn't really know how to cook for them. But when they would set goals, they would set these really huge goals. So you'd have somebody who would, say, well, I usually put about a tablespoon of salt on my food. So my goal for this week is not to use salt at all. And people who make goals like that often aren't able to make it through the entire week because it's such a drastic change. So what we really encouraged in people was to pick a small change, and pick a small change that you think you can do for more than a week. Because if you can go from 12 shakes of the salt shaker to 10 shakes of the salt shaker, maybe you could keep that up for a longer period of time, and maybe once the food tastes pretty good like that, you can go down to 8. And just sort of keep working your way towards what your goal is. So what you're looking for is not a behavior change today, but a behavior change that actually can be sustained over the period of a long time. Some small change strategies, the stealth exercise that I mentioned, getting people to get off the bus, a block early. Walk just a little bit more, get up. If you have to watch television and you have to do it first thing, when the first commercial comes on, can you get up and walk around your house until the program's on again? So just trying to build in ways that the person can exercise more without it seeming like a huge ordeal or a huge commitment. Sometimes in Chicago, particularly, in Louisville as well, people don't want to walk, particularly women, because they're afraid of what's going to happen if they walk outside by themselves in their neighborhoods. And we have a lot of people who lived in neighborhoods where, you know, they might find dead bodies in their front yards, or, you know, people would be shooting at each other in the streets, and they didn't want to get caught up in that. So if we had people in really high crime areas, one of the things that we did were walking groups. And that actually, in addition to making people feel like they aren't going to be in danger by themselves, makes people feel like they have a group that they're accountable for. And you'll hear things like, I didn't want to go walking, but I knew she didn't want to either, and she needed to, so I went to her room and I got her. You know, so people will sort of help to keep each other motivated, and it can be quite a social thing. So you walk and you talk, and it's a lot of fun. Food wasting. Sometimes if people are very attached to getting their food, you know, pre-prepared, and it comes in a certain size, and that's, you know, all you can do, you can encourage food wasting. So that, you know, you can go to McDonald's and you can get the #1 meal, but, you know, don't eat your French fries first. You know, eat the hamburger first. Don't eat all the hamburger, and by the time you get to the French fries, they're going to be cooling down, and there's nothing that tastes worse than cold French fries, so you don't have to worry about that either. And there's a man in the East Coast who actually has had significant positive results with just encouraging people not to eat everything that is on their plate. Actually, the other strategy for this would be to use a smaller plate. We did an exercise with our group that had them, we would bring in three bowls of different sizes and get a box of cereal and say, okay, well, pour a half a cup, you know, because that's the serving size. And so then we'd measure them, and, you know, the small bowl, you'd be close to the half a cup. The larger bowl, you'd have maybe a cup, and the really big bowl, you'd have more like a cup and a half or 2 cups. So just sort of keeping your plates a size that's smaller makes it look like you have more food, and that makes it easier to feel like you've had enough. And then I think introducing healthier choices. You know, how can you start to introduce more vegetables, more fruit, fewer fried foods, and, you know, I'll tell you, anything in Karachi I think would have to be organized around Hirani, because it's amazing. But you know, sort of how do you take the foods that you love and start adding in foods that maybe are a little bit healthier, so that you get both. Actually, before I leave that, there's a right now, I know that you've all seen the food pyramid, but under the Obama administration, they've actually changed, because most people find the food pyramid really difficult. You know, it's got like a ton of different levels, and particularly people with mental illness. You know, they're not going to look at these 7 things on the pyramid and the person walking up the side and think, okay, yes, I can fit this into my life. So there's a group that's developed a method called the Idaho Plate Method. And it basically takes a plate and it divides it in half, and then it divides 1/2 into quarters. And it says just basically make your plate look like this. So half of your plate is vegetables and greens. Half of the other half is starch, and half of the other half is protein. So how do you incorporate this very simple model? And in fact, I developed a cookbook for the program that had, full-page vegetable recipes, and then half-page protein and starch recipes. And if you had a whole page together, you know, if you had like a whole thing together, then you had your Idaho plate. Okay, so there are a lot of things we can do. I think it takes a lot of creativity. I think it takes a lot of patience. I think it takes a lot of sort of interest, and I think it takes some trust in people that they want to do what is best for them the same way you or I do. And that we just need to help them figure out what's going to be the workable solution for them. So in summary, people with mental illnesses are at greater risk for serious physical illness. Medications and lifestyle factors contribute to this risk. They are less likely to see primary care providers. And when they do see primary care providers, they are less likely to get treated. They are less likely to get standard of care. People with mental health diagnoses are more expensive to treat in primary care. And they also use more services. So they tend to go to the doctor more and you know, get worked up for more things. Medical and psychiatric illnesses are less likely to be well controlled, but they're going to be more expensive to treat. Yeah. But this is the last one, so it's actually sort of. Am I okay. Psychiatric rehabilitation programs are in a unique position to integrate care, and that's because they can identify processes for tracking services and outcomes. They can look at how people are doing. They can develop forms. They can collaborate with providers, and they can work with patients on developing a plan that's good for them. And if we prioritize for this group, if we prioritize physical health as well as mental health, people will have better outcomes for both, okay? And they will live longer lives. And so I really think that that's an important task for us to embrace. Okay.